Hello, everyone. Good morning, good afternoon, or good evening, depending on where you're joining us from. Welcome to the third edition of the ISARIC COVID-19 Evidence Forum. Today's session is on the use of convalescent plasma in patients that are hospitalized with COVID-19. My name is Bharat Kumar. I'm an intensive care physician working at Apollo Hospitals in Chennai, in southern India, and I'm honored to be today's moderator. We have 4 excellent talks that are lined up. Before we get started with the session, I have a couple of slides and some information relevant to today's session. I'm just going to try and move my slides. Yeah, great. So no relevant financial disclosures for me. I do take care of patients that are hospitalized with COVID-19, and I lead and participate in clinical trials investigating therapies for COVID-19. I'm not involved in any trial of investigating the role of convalescent plasma. That's my email address, and that's me on Twitter. The partners for today's event are the International Severe Acute Respiratory and Emerging Infection Consortium, or ISARIC, Apollo Hospitals, specifically the Chennai unit, the Indian Registry of Intensive Care, and the George Institute for Global Health in New Delhi. These are the social media handles of all our partners. And if you're tweeting about this event, please use the hashtag ISARIC. ISARIC is also on Facebook at ISARIC Global. This session is being live streamed on YouTube, and you can watch it there. On your screen, you should have 2 panels. One is a chat window, another is a question and answer window. If you're posting a question, please use the Q&A window and not the chat window. If your question is for a specific speaker, please do identify that in your question. Some of your questions we will take up for discussion in the last 10 minutes, and the rest will be answered by the speakers in the Q&A box. So why this forum? All the partners that are part of today's session are invested in the dissemination of published evidence and its translation to clinical practice. We are also interested in identifying key knowledge gaps and some of the residual uncertainties, not only surrounding the use of convalescent plasma, but also for other therapeutics. And we hope to do this through stakeholder engagement and events such as today's forum. So this is the agenda for today. With this, I'm going to call upon our first speaker. Our first speaker is Dr. Aparna Mukherjee. Dr. Mukherjee is a medical doctor and senior scientist at the Indian Council of Medical Research. She works on clinical trial and health systems research unit there and in the epidemiology and communicable diseases divisions. She is a pediatrician by training. Her research interests include pediatric pulmonology and pediatric infectious diseases, in particular HIV and tuberculosis. Specific to today's forum, she was one of the main investigators of the PLACID trial, which evaluated the role of convalescent plasma in Indian patients. This trial has been published in BMJ, as several of you may be aware, and today she'll be presenting the results of the trial. Dr. Mukherjee, it's a great pleasure to have you. Over to you.
Thank you. It's nice to be here presenting in such a forum. So if I please may have my slides. Yes. So I'll basically be presenting the findings from our study on behalf of the whole PLACID trial team, because as we all know that RCTs are a concerted effort from a team and never from one person. Next, please. So as a placeholder before I go into the study, I would just like to remind you that the whole idea of convalescent plasma in infectious disease started because it does have antiviral neutralizing antibodies, which theoretically has the potential to neutralize the virus, as well as there are other mechanisms of antibody-dependent cytotoxicity, anti-inflammatory cytokines, which may also be helpful. Next, please. So at the beginning of the pandemic last year, we basically designed this trial. This was an open label, parallel arm, phase 2 multicentric randomized controlled trial. It was conducted across India, 39 centers were involved, and we included adult patients who were hospitalized with the diagnosis of SARS-CoV-2, RT-PCR confirmed, and they were moderately ill as per our guidelines, which basically meant that they had a PA to FiO2 ratio between 200 to 300, or their respiratory rate was more than 24 with an SpO2 less than equal to 93%. And our primary outcome was a composite measure of progress to severe disease, which was again defined as a PF ratio less than 100, uh, or all-cause mortality within a span of 28 days. Next slide, please. So we had an intervention arm where we were giving 2 doses of 200 ml convalescent plasma, 24 hours apart, along with whatever was the best standard of care available at that time. And we had a control arm which was giving only best standard of care. This was open level. We did not have any placebo in the control arm. And we did do microneutralization tests for the SARS-CoV-2 neutralizing antibodies, but that was done on the stored samples, both from the donor side as well as from the recipient side. For the recipients, we did it on 0, that is before the transfusion of the plasma, and also at 3 and 7. Next slide, please. So this is a general trial profile where we had patients 464 ultimately randomized into the trial, 235 into the intervention arm and 229 in the other arm. We did have some loss to follow up and some withdrawal of consent. So ultimately in the analysis and intention to treat analysis, we had 235 in the intervention arm and 229 participants in the control arm. Next slide, please. So just to give you a picture, this is the baseline characteristics. We generally had male patients with a median age of 52, and they were amongst the comorbidities, diabetes was the most common one, and diabetes was basically a bit more in the intervention arm, so we did adjust for this later on, as well as the duration of symptoms before they got randomized was on a median 8 days. So that's not very early, but not really very late. But interestingly, when we did the neutralizing antibodies for the participants, we found that about 86% of them already had neutralizing antibodies in their plasma. Next. The donors, as per the international regulations, we had men or nulliparous women, 18 to 65 years of age, more than 50 kg. And we took patients, we tried to take COVID-19 recovered patients who at least had some symptoms. And they were at least 28 days from resolution of their symptoms, or 14 days if they had an RT-PCR negative. Next slide. But before we go into the outcomes, I should say that we did end up having donors who were predominantly male, who were young, with the mean age somewhere around 35, and most of them had only mild disease with cough, fever, and were not hospitalized. So that translated into the donated plasma having less of antibodies than what we would have expected or we would have liked. So when we come to the primary outcomes that we had, what we found that the composite outcome was found in 844, that is 18.7% in the intervention arm and 17.9% in the standard of care, where there was no statistical difference. And if we do break it up into the mortality and progression to severe disease, again, it's like 14.9 and 13.8 in the two arms, which is like very close, and there was no statistical significance. Next slide, please. Though we were not really powered to do this kind of subgroup analysis, but still we tried to do it to compare the intervention arm where detectable neutralizing antibodies had been transfused via the convalescent plasma, which was in 160 patients. When we compared it with the control arm, again, we found a composite outcome of 17% and 18%, which definitely did not have any difference. Again, if we took more than 1:80 neutralizing antibody as a semblance of high titer, there was no difference. The other way around, because there is a theory that if the recipient is seronegative, convalescent plasma might work. So if we took those recipients who did not have any neutralizing antibodies in their plasma and compared it with the control, again, there was no difference. Though I admit these are all very small numbers, but then we could not really detect any trend or any signal from these subgroup analysis. Next slide. In some secondary analysis, which I've not put here, we did find that the patients did say that there was an improvement in breathlessness, improvement in fatigue. These were the two symptoms which resolved in higher proportion of patients in the ones who received convalescent plasma at day 7. But the other symptoms like fever, cough, they did not resolve better in the convalescent plasma arm. So this could be because this was an open label trial and there could be some subjective assessment in terms of fatigue and in terms of breathlessness being resolved. The one positive finding that we did find was that the RT-PCR becoming negative, that proportion was definitely higher in the convalescent plasma group, starting as early as 3 days. But then that we already knew that there are antiviral antibodies, so the viral load should be coming down. But what is of interest is that does it translate into any clinically meaningful impact, which we could not find. Obviously, this trial does have some limitations. Though this was the first completed trial on convalescent plasma anywhere in the world, but then it did have some flaws, like it was first of all an open label design, which obviously lets bias creep in to some extent. Then we had 39 sites, so some amount of heterogeneity could be expected. There was some clustering of enrollment because obviously the hotspots could enroll more patients than the others. And most importantly, we did not measure the antibody titers before transfusing the plasma. It was only after the trial, the stored plasma were all assayed. And as has been seen in subsequent other trials also, that the recipients who were on a median 8 days from their symptom onset, they already, most of them, more than 80% of them already had neutralizing antibodies. Next slide. Yeah, before I go to this, I would also like to say that the strength, in spite of these limitations, the strength of the trial was that it kind of was a pragmatic trial. It reflected what was actually happening in the country at that point of time. Most of the centers were transfusing without really measuring quantitatively whether how much antibody is there and what is the titer. And people were receiving plasma at all stages of the disease. Even severely ill, critically ill patients were receiving plasma. So it basically reflected the real world scenario, which was a big strength of this trial. So it brought us in this juncture that we realized that there were some ethical and implementation concerns related with convalescent plasma. One, there was a frantic call for convalescent plasma, which we also saw in the second wave in terms of getting plasma donors and getting plasma, and there were reports of black marketing of the plasma. And it's a relatively safe therapy, and we have been using this in other diseases also. But still, even saying that, it is a resource-intensive process where you collect the plasma, store it properly, transfuse it. So in a setting where the healthcare system is already overloaded, to focus our resources on this would be prudent only if we are very sure that, yes, this is going to work. Otherwise, you are basically forcing the recipient's family members to undergo a total guilt trip that you really have to get plasma, and then this is the only thing that can save you. So that was the narrative that we wanted to prevent. Next slide, please. Before I finish, I would just like to take you through some journey. This was a very interesting trial in the sense that we did it in the times of when the whole nation was in lockdown. So there were a lot of constraints, like where do we do it? Where do we do the assays? How do we actually enroll the patients? Enrolling the patients was still there because they were coming to the hospital, but how do we get the donors? Because at that point, once a person went back to home, they really did not want to come back to hospital to donate. So We tried as much as we could to democratize this, to spread it across the country so that we get a representation from all across the region as to what treatments are being done and what practices are being followed. And we ensured that all these things are done free of all the treatment, everything is done free of cost. And each hospital had a multidisciplinary team and not only one single PI. And the donors were contacted personally with phone calls, and measures were taken to get them from their home during the lockdown so that they did not suffer. So these measures were actually taken. And data quality assurance, that was another challenge doing in our city in that complete lockdown, because we really couldn't visit any site. So it was all virtual. So we had to take training and refresher training virtually. We had to have the investigator meetings regularly virtually, and even the audit we had to do virtually, so that they uploaded their source documents. We went through whatever they were doing virtually. So that was a very interesting experience for us. And lastly, though we have taken a lot of flack for this, but we made sure that credit was given to all that were involved, because it would not have been possible without all our collaborators to actually do this trial in such short time, in such restrained, lockdown environment. Next slide. Ultimately, what we are currently recommending after a long journey, and with the support of the subsequent trials that have come up, larger ones which have supported our view, is that there is no therapeutic benefit of convalescent plasma in preventing progression to severe disease or mortality when given to moderate to severe COVID-19 patients. So recommendations on our national guidelines have changed gradually from where we were in April 2020. And right now we are not recommending convalescent plasma in hospitalized patients. So that's it from my side. Thank you.
Thanks, Dr. Mukherjee. Great talk, and more importantly, of course, providing context to your results and briefly touching upon the challenges of doing this, especially in the first wave when we didn't have vaccination and there were lots of other issues going on at that time. Thank you so much. Our next speaker is Dr. Peter Horby. Dr. Horby is a professor of emerging infectious diseases and global health at the University of Oxford. He has led clinical and epidemiological research on a wide range of emerging pathogens, including avian influenza, SARS, Ebola, and of course, COVID-19. He is well known to all of us as the chief investigator of the recovery trial, which is the largest trial of evaluating therapies for COVID-19. And I think we can all agree that it's probably also been the most impactful trial as far as COVID-19 is concerned. To date, recovery has enrolled nearly 40,000 patients. It has already provided answers for us on a number of molecules. Just a couple of days back, Professor Horby and colleagues have published the results for the aspirin arm of the recovery trial as a preprint. So it's great to have Professor Horby here. He will be sharing the results of the convalescent plasma arm, and this was published in the Lancet. Thank you, Professor Horby. Over to you.
Great. Thank you very much, and thank you, Dr. Mukherjee, for that great presentation. Can you just confirm you can see the slides?
Yes. Yeah.
Great. Thank you very much. Okay, good. So I'm going to briefly take you through the convalescent plasma results from the recovery trial. As you probably know, this is a large platform trial, mostly in the UK, but now expanded to some other countries. And convalescent plasma was one of the interventions that we evaluated. Just the methods first, I'll go through briefly because Dr. Mukherjee has given some of the background. This was a platform trial with factorial randomization, so you could be randomized at different levels. And we had a specific randomization called randomization B for antibody preparations. So patients could be randomized in a 1:1:1 ratio to no additional treatment, so standard of care, convalescent plasma, or a synthetic monoclonal antibody, Regeneron-COV2. This was hospitalized SARS-CoV-2 infections and included pregnant women and children in the trial. And the only exclusions were allergies to blood products or refusal to accept blood products. The intervention was 2 units of ABO-compatible convalescent plasma, so 1 unit on study day 1, and the second units between 12 and 24 hours after the first unit. And if possible, the 2 units should be from different donors, and in reality, that is what happened in the trial, to try and increase the probability of getting at least 1 higher titer plasma unit. But all the plasma units were high titer, so they were screened by the National Blood Transfusion Services, and only those with higher titer were included in the trial. And that was using a Euroimmune is the name of the immunoassay cutoff of greater than or equal to 6. And the Food and Drug Administration have subsequently defined high titer using this assay as greater than equal to 3.5. So according to FDA definitions, all of our plasma units were certainly high titer and above the FDA cutoff. We took a serum sample from all patients before randomization because from the prior trials, including Dr. Mukherjee's and others, there was an anticipation that the effect, if there is any benefit, would be strongest in patients who were seronegative at baseline, so did not have their own antibodies. So we didn't screen patients. We took a blood test, and post hoc we could categorize patients into seropositive or seronegative or unknown if the blood sample wasn't taken. So our outcomes are the same across the whole recovery trial. So the primary outcome is mortality at day 28, and we're also looking at 6 months. Secondary outcomes are time to discharge from hospital, and among patients who are not on invasive mechanical ventilation at randomization, their progression to either invasive mechanical ventilation or death as a composite outcome. We had 7 pre-specified subgroup analyses: age, gender, ethnicity, level of respiratory support at randomization, days since symptom onset, 7 or more, use of steroids, and the presence or absence of baseline antibodies in the patient. And there were some other pre-specified clinical outcomes: all-cause mortality, receipt of any kind of ventilation, cessation of ventilation, or receipt of renal replacement therapy. So the trial population that we enrolled 11,500 patients in the trial. In this part of the trial is now 40,000 patients, but for the convalescent plasma comparison, it's 11,500 patients. So 5,795 were given convalescent plasma, and 5,763 were allocated usual care. And it was an intention to treat analysis. So all of those patients, whether they withdrew or didn't receive the intervention for whatever reason, were included in the intention to treat analysis, which is the most sort of conservative analysis. Patients were slightly older than the trial we just heard about. The median age was about 63.5. More men than women. We see this throughout these hospitalized trials. There's a predominance of men in hospitalized COVID patients. Majority of patients were white ethnicity, but about 14–15% of Black, Asian, or ethnic minority. About 9 days since symptom onset, and about median of 2 days since hospital admission to being randomized, which is again sort of pretty standard throughout the recovery comparisons. And this is the level of disease severity. We didn't specify a severity, you just had to be hospitalized, but just about 8% were not on any oxygen therapy. The vast majority, 90%, were on oxygen, and that would include non-invasive mechanical ventilation, CPAP, etc. And about 5% on invasive mechanical ventilation at randomization. Vast majority PCR positive. It's not a requirement at enrollment to be PCR positive because there's sometimes a delay in getting the blood result, but when we finally get in all the data, the vast majority are PCR positive. And when we do a sensitivity analysis, excluding those who are negative, it makes no difference. And about half seropositive at randomization. So this is using the blood sample taken before randomization, but in a post hoc testing, about half is antibody positive at randomization, and about 30% are seronegative. And we have missing data for sort of 12 to 20%, which means that the blood sample wasn't taken. And most patients at this time were on corticosteroids in line with the changes in practice since June last year. So the results, no difference in all-cause mortality. So really absolutely no difference. The rate ratio of 1 for 28-day mortality. So the primary endpoint was a fail, no evidence of any benefit. When we look at that by the pre-specified subgroups, again, there was no evidence of any benefit in any of the subgroups. So no benefit by age, gender, ethnicity, time since onset, respiratory support, use of steroids, or baseline antibody tests. Although you can see the plots crossing the line, none of them are significant. And if you look at the p-values there for the chi-square test, you can see that there's no statistical evidence of heterogeneity between those subgroups. So none of those p-values are significant. So there's no evidence of any heterogeneity of effect by these subgroups. And all of them suggest no benefit on 28-day mortality in this patient group. Interestingly, though, when you do look at if this is just a plot of some of the data you just saw, looking at the 28-day mortality by baseline serostatus, you can see that actually being seronegative is a big risk factor for death. So the mortality in seronegative patients is over 30%, as opposed to about half that in patients who are seropositive. So clearly mounting your own antibody response is at least a biomarker of prognosis. Whether it's causally related, we can't say. But these two plots, you can see, although convalescent plasma is below usual care in the seronegatives and it's the other way around in the seropositives, neither of these results was statistically significant. So we can't really say there's any heterogeneity there. We did some post-hoc analyses to look in more detail if there was any evidence of benefit in a more refined subgroup analysis. But if we looked at days since symptom onset, going from 4 or less right up to more than 12, again, no real evidence of heterogeneity there. You might sort of perceive a trend there with more benefits earlier treatment, but the p is 0.08, so you can't say that that's a real effect. It could just be chance. And the same with respiratory support. Certainly, it looks as if there may be more harm in the more severe patients and more benefit in the less severe patients, but again, not statistically significant. And we looked at data randomisation because we had a change in the serotype of the virus variant in the UK, and we didn't see any difference of that change in variant to the Kent variant. If we put that in a meta-analysis of all trials, you can see there that the trial we just heard about, Agarwal is the primary author. We put it all into a meta-analysis. It's all consistent. There's no heterogeneity between the trials statistically, and overall hazard ratio of 0.98 and not significant, so no benefits overall. And this is just showing you the secondary endpoints, the secondary outcomes, median duration of hospitalization, discharge from hospital, progression to IMV or death, again, not statistically significant. And the secondary subsidiary outcomes at the bottom there, no evidence of benefit. I just quickly finish, I know I'm running out of time. If we look at the subgroups by the secondaries, what you can see, if I direct you to the bottom there, this is discharge from hospital. If you look at the antibody positive negative, there is heterogeneity there, so the p is 0.008. So there is evidence of a different effects on that secondary outcome between seropositive, seronegatives, with a tendency towards a small benefit in seronegatives and a small harm in seropositives. And the same if we look at the secondary outcome of progression to IMV or death in those not on IMV. Again, some evidence of heterogeneity, p 0.01 at the bottom there, with some evidence of a small benefit in those who are seronegative and no benefit in those who are seropositive. So in summary, in hospitalized COVID-19 patients, really no significant difference in 28-day mortality overall or in subgroups, so no mortality benefit. However, you look at the data, and overall no significant difference in proportion discharged alive, no significant difference in progression, but there is some heterogeneity in secondary outcomes. So we can't exclude the possibility of a small improvement in successful discharge or progression to invasive mechanical ventilation or death in seronegative patients, but it is a small difference, and it's only about 30% of the whole patient group. So I think that would need to be confirmed, and I think the real place for convalescent plasma, if anywhere, is outside of hospital in very early treatment, and that needs to be confirmed in randomised trials. Thank you very much for your attention.
Thank you, Professor Hobby, for a great presentation, and many congratulations to you and the entire recovery team. We'll take some questions at the end. Our next speaker is Dr. Soumyadeep Bhaumik, and we will be shifting gears a bit with this talk in terms of both evidence synthesis, but also on some of the challenges of translating evidence to bedside practice. Dr. Soumyadeep Bhaumik is a medical doctor and international public health specialist working at the George Institute in New Delhi. He has a demonstrated track record of impactful work in the areas of evidence synthesis, science advocacy, and which in turn has informed policy, practice, and public debate. He is interested in the areas of meta-research, health policy, and snakebite, and has a keen interest in moral philosophy and ethics in public health. He is an associate editor for evidence synthesis at BMJ Global Health and co-convener of the Cochrane Priority Setting Methods Group. It's a great pleasure to have you, Dr. Soumyadeep, here. Over to you.
Thank you. Thank you for inviting and also for the introduction. And it's really a great pleasure to have a discussion around this topic. And the background for this has already been laid down for my talk in the form of the two very big and important trials. And so I just take that forward into how this operationalizes in the from the point of view of a pandemic. So first of all, I don't have any conflict of interest specific to this topic. I have not participated in any trials or do not have any other non-financial interest with relation to this topic. So just a very quick run over convalescent plasma has been there from a really long time, but its popularity declined due to the use of antibiotics. But it did make a comeback as COVID-19 came over. And when this happened, slowly studies started trickling in, and these were very small pilot studies, and the FDA also started making recommendations initially for investigation COVID-19 use and then also for emergency use. And as and when more and more studies kept on piling, its use became popular quite across the globe last year. And it was at also this time when randomized control trials were happening, and there was a growing interest on the use of it, and many clinicians very strongly believed that it was really working. And these small case reports and case series were adding evidence to that. But the first of it actually came through another very small study, which actually found that it might be that there is no evidence that convalescent plasma helps in COVID-19 treatment. Again, this was not a randomized control trial, and the first real evidence from randomized control trial came from the PLACID trial, which Dr. Aparna already talked about. And in terms of the totality of evidence, which was also already mentioned by Dr. Horby, there's a very robust Cochrane systematic review done, and which does really show there is no benefit due to all-cause mortality or other important outcomes like invasive mechanical ventilator use or like that. But I would just like to point one more thing, and this is something which people like me who work more on the interface of evidence to policy and practices. Whenever we talk about these numbers, people do ask us, how confident are you that this will work? And this means that it's just not about the estimates, it's also about being able to say how certain we are that what we are seeing will be true in the future. And for this purpose, we of course have the GREED, and which is a scientific methods and uses various parameters, 8 of them more specifically to upgrade or downgrade an evidence based on these factors, to be able to, for us to say that whether I'm very highly certain, which means that further research is unlikely to change our confidence, or we are not so certain whether it's a moderate certainty or very low certainty or low certainty, whereas very low means like I'm totally uncertain and things might change as future research comes on. And we do see that based on the totality of evidence for some very important outcomes, as Professor Horby was mentioning about, there is quite a high certainty of evidence that convalescent plasma would not help improve or provide clinically important benefits. So under this background, with all the evidence available at that point of time, India did have its second wave of COVID-19. And as we know, evidence does not sit in a vacuum. And hospitals did started getting a lot of patients. The health system was also on a complete overlock. And with many celebrities joining the bandwagon of donating plasma, because that was something which was seen as something that can save lives. And this is in April 2021 with many trials done, and also the preprint of the UK trial already available. And but this still kept on going on. There was black marketing, and some people were donating plasma like anything. It was under this context of things that people were just left running for not only ventilator beds and oxygen, but also plasma, and the resulting humanitarian crisis, which we have all seen and worked on. And when this all this happened, when this was going on, the 22nd April, our national guidelines were revised after a span of few months, but it did still have convalescent plasma, which was mentioned as an off-label use. And we initially started reaching out to clinicians and also to various digital volunteers who were helping patients get plasma, and started talking about them with evidence, telling them about what has been the finding of the ISARIC Placid trial, what is the totality of evidence, telling them about the UK trial, which is really large and also shows subgroup analysis, and why we should try preventing it. We did a lot of social media outreach. We also started talking to a lot of clinicians and clinicians groups who were active. And these are like some of the actual quotes which some of us who were working in this space got back. And it was then at this point we realized that we really need to work a step further, which was in working on guidelines. And at this point, a few of us, around 18 of us, doctors, public health people, as well as some other scientists, wrote to the principal scientific advisor, asking them for a revision of the guideline and reconsider to do that. And we were very lucky that it was indeed done, and plasma was removed within 7 days from the guidelines. While this was indeed achieved, working in the evidence synthesis space, we do want long-term solutions. And and we find there are still a lot of problems with our guidelines. Essentially, it's in the form of a flow chart. And these do not really tell us what is the effect of different outcomes on of an intervention on different outcomes. Because as a clinician, if I have to deliver high quality care, I should know what is the effect on different outcomes, which the systematic reviews does, which the trial does. So there is some element of granularity and information that is needed, other than just saying that, okay, these are the drugs and this is the flow chart to follow. We would also like to see some evidence synthesis and grade profiles backing this up, information how these decisions were arrived on, and more importantly, we would very much like these decisions to be done by a larger number of healthcare people, including patients, and also with transparency and accountability in terms of providing information of competing interests of those who are involved in guideline development, and what happens and how these were addressed. All of this means that as an overall at a systems level, clinicians are very much delivering no to low value care, because it's very difficult to know that the care I'm giving is actually low value or high value, because in a guideline which does just provides information on these are the drugs to give and these are not the drugs to give, I cannot differentiate on the basis of it unless I start looking out for evidence on this domain. And luckily we do have frameworks to do that, and this is something that should be done by a panel involving uh, uh, trialists, but also involving from people from primary care physicians, healthcare workers, nurses, and most importantly patients, who are the very important stakeholders in this. And there are frameworks that has been developed, and a very big advantage of having a framework like this is that it makes the journey from evidence to decision making explicit and transparent, and it facilitates the decision so that no important factors are missed out, or because of the constitution of the guideline development group or the committee which is making the guideline, there is no undue weightage given to one particular factor, because this is quite a structured arrangement, and it looks at whether it's a problem, what are the and how substantial are the desirable and undesirable effects, what are the values at that point, and what is the balance of effect. So, and you can see like evidence is just 2 or 3 points within it. A larger body of decision making is about resources, and Dr. Aparna already mentioned about that, and also cost effectiveness and equity. And as we can see that what happened during the second wave is that beds were scarce, and people with mild to moderate diseases who were richer and could afford so would get admitted just to get convalescent plasma and get some small benefit, whereas people who were more severe and didn't necessarily have the resources for this purpose really struggled to get beds during the second wave. And I think this gives, using such frameworks like this gives us a lot of learnings, and we learned that we cannot stop after conducting trials or evidence synthesis. We really need to engage more and work towards making our guidelines high quality and develop so that there is capacity and reorientation of culture of medicine towards high value care. We also would want the guidelines to make very strong against recommendations. I think this point of not making an against recommendation is quite typical in our country. It might not be applicable in a lot of settings. But overall, there's also a capacity gap for evidence-informed clinical practice, which really needs to be worked on. Without which we might be conducting trials, but we might be getting very high quality evidence synthesis or guidelines. It will not get implemented because people are need to be confident and sure not only about how important these gaps are, but also about how certain we are and how confidently we can do it, and also understand the dynamicity of the pandemic when making clinical decisions. Thank you.
Thank you so much, Dr. Bhaumik, for an excellent talk. We will try and circle back to some of these challenges in the Q&A if time permits. Thank you so much. Our next speaker is Dr. Janet Diaz. Dr. Diaz is the head of clinical care at the Health Emergencies Division at the World Health Organization. She previously served as the medical director of the intensive care unit at San Francisco General Hospital and as an assistant clinical professor at UCSF. From 2010, she has been leading the clinical response team at WHO, and of course has continued to do that for COVID-19. Today she'll talk to us about the WHO living guidelines. Thank you, Dr. Diaz, for joining. I know you're very, very busy. Thank you so much for making time. Over to you.
Thank you, Dr. Barath, and thank you to the organizers of the meeting, to the colleagues from ISARIC for this opportunity to present to you on the, so I'm going to try to show my slides, and now I'm hoping I don't mess this up, sorry. Let's see. There you go, is it okay?
Yeah, it's working. Yeah, thank you.
Okay, we had a little bit of problems with the slides earlier since yesterday. So it's a pleasure to be here. I'm going to just go through a little bit of the step-by-step approach from WHO to developing our living guidelines for therapeutics in COVID-19, and just to really echo some of the key points the colleague before me spoke of, and what kind of a challenge it is actually to provide living guidelines, which means that they're timely, transparent, and trustworthy, and that the clinicians, trust them enough to use them, to integrate them into their clinical practice. And this continues to be a challenge for us as well on the global level. We know why it's challenging. It's because there's clinical practice continues to be very variable, even though we now have much more evidence than we did, over a year ago when the pandemic started. We know it's a challenge because there's so many trials ongoing. Some are robust, large platform trials. And so thanks to colleagues such as those doing recovery trial and Solidarity to provide us with such high quality work. But we do know there's smaller trials out there as well. And bringing all that evidence together is a challenge. And we do know that things come out in different forms, some in peer review, which is what we were used to before the pandemic, but now also in preprints, and then some in press releases. At WHO, one of our roles is to provide norms and standards, and part of that is writing guidelines. In the past, a guideline at WHO probably took between 3 to 5 years, and that is true for some of the groups working on guidelines here, and that obviously is too slow for anything that would be useful in a pandemic. And unfortunately, also too slow for non-pandemic times where potentially a recommendation could come out after more evidence is done, but because it takes so long to process through the system that it can be actually even outdated. So what we decided here for this therapeutic and COVID-19 living guideline was, can we do it faster? So how can we set up our system to move within weeks to months to write a guideline rather than months to years, and that guideline or that recommendation matters at that moment when it's published, that it impacts, and that it's not outdated already because a new trial just got published. So it really requires careful monitoring of evidence generation. So the trials that are either enrolling, soon to finish enrolling, DSMB's meeting, so that we can kind of stay just aligned with the evidence generation in order then to convert it into a recommendation. So the process then is a cyclical process. It feels like we're here always trying to update the guideline, updating the systematic reviews, discussing with trialists, convening a GDG, disseminating the guidelines, and then already the next one. And so that's what we've tried to put in place here with the guideline development process. Just to highlight our guidelines right now, we have 3 different products. One is the guidelines for therapeutics in COVID-19. That has been updated probably on about 6 to 8 weeks time frame. We have a clinical management guideline, which is a very comprehensive one, which is more a holistic approach to clinical management, including the supportive care interventions. And then we have a guideline on drugs to prevent COVID-19. These are all published on the WHO website, but we also have been publishing our guidelines in the BMJ, as well as on the MAGIC electronic platform. So those for more easy to read formats. And currently, as you can see with this color coded on the right, we have recommendations for corticosteroids, a strong one for patients with severe and critical disease. We have a conditional recommendation against remdesivir. We have strong recommendations against lopinavir, ritonavir, hydroxychloroquine. And for ivermectin, we actually ended up recommending against, except for use in clinical trials. I want to emphasize Although we're looking for the magic bullet with a drug, we know that's not going to be on its own the magic bullet. So we must take care of patients holistically. So doing the basics well, and then of course here would be oxygen use, which we know was also a big has been an access problem in many countries when they're experiencing such peaks. So having good access to oxygen, appropriate use of oxygen in the context of also using steroids and thromboprophylaxis. And this is just highlighting our clinical care bundle, which emphasizes 5 evidence-based practices for patients with COVID-19. To discuss the guidelines again, so here is the step-by-step approach. We monitor the evidence, so that's the evidence generation, taking a close look at the platform trials, also looking at trials that are recruiting in many countries around the world, and making sure that they are collecting sufficient numbers of enrollees and events. We then go into evidence synthesis, and I'm going to highlight the couple of types of evidence synthesis that we work with our colleagues on: the living network meta-analysis, the prospective meta-analysis, as was already described, the grading of the evidence, so trying to understand the certainty in the estimates. We develop pre-specified subgroups, and we use patient-important outcomes, and I'm going to highlight this in the next slides. Then we go into drafting the recommendations, and we do so with an independent guideline development group. Again, this is hugely important, as colleagues described just before. Those that make up the GDG, we try our best to have regional representation and balance different types of specialists, from primary care to the ICU doctor to the infectious disease doctor to an ethicist, and patients in that panel. So really trying to get kind of some sort of good representation globally to participate, because that's the group that actually writes the guidelines for us. It's an independent panel. They are all free of conflicts of interest, and they pre-specify their values and preferences, which are based on patient-related values and preferences, and use a very classic evidence to decision framework to make the decisions. And then we publish our guidelines. And this is a relatively simplified approach of a lot of work that goes on to write a guideline. For the systematic reviews, again, colleagues before described how important it is, and you know, there's many people doing systematic reviews out there. So just to highlight some that we've been using, one is the living network meta-analysis that's been done by the McMaster group. This network meta-analysis, actually, most of our recommendations, when we are about to trigger the systematic review update, we pre-specify the subgroups with the GDG. So we actually tell them, how do you want us to look at this data? And then we tell the systematic review team to process the data and the updates according to what we would like. I think that's an important concept. And of course, the network meta-analysis, right, which I think in the near future is going to become much more important because of the way more drugs are going to come out, and how can we compare drugs that necessarily weren't compared directly in a trial, but indirectly through a network. We also have the prospective meta-analysis, which was an approach taken in order to try to get the analysis done in a more timely fashion. So not waiting for the publication of the studies, but rather already being in contact with trialists and developing the meta-analysis protocol with the trialists, but with an independent methods team in order to see, can we aggregate data faster that way, and also look for patient important outcomes. So that's also been another innovation for this outbreak. And then of course, the living NMA that's on the WHO website that gets updated on a daily basis. Just to highlight the prospective meta-analysis, this slide is from colleague Jonathan Stern at Bristol. Again, the approach here was a huge collaboration, and some of you have been part of this collaboration. We have done this for corticosteroids, and we are just finishing our prospective meta-analysis for the IL-6 receptor blockers, looking at tocilizumab and sarilumab, and that guideline actually will be published within a week or 10 days potentially. And so here, really a collective approach to try to bring data even before the studies have finished in a pre-specified way. And then once studies have finished enrollment and have their outcomes, to share it at the same time as the studies are also writing up their manuscripts, submitting for publication, and trying to get this to inform guidelines faster. At WHO, we have a guideline handbook. It's available on the website, and it really tries to say step by step, what are the approaches? As already described, the grading of the evidence is one of the most important things. And what is the certainty of those results, which is always what we're trying to see. How certain are we in the estimates of effect? We have a clinical chair, which tries to be the clinician, the chief clinician in the room, who helps the group find consensus, brings perspectives. And we have a methodologist, which provides the technical support, making sure that the grades are all done. We have patient important outcomes. So these are the way we prioritize. And we do this with the group. And we do this not every time, but we do ask the group, do they want to reprioritize? Are these still valid outcomes to prioritize? And you can see there can be different ones for the inpatients, where mortality is number one, then mechanical ventilation. And on the right for outpatients, where admission to hospital was the primary outcome, and then death, and then quality of life. So these are things that we can reassess with our GDG on a regular basis to ensure that we're still reflecting what they feel is the patient important outcome. Ideally, this would be done with much more patients, and we are trying to get a patient survey, a large-scale patient survey, in order to help improve this prioritization. As was already shown with the Grade Pro, we use a very similar summary of findings table where we summarize all the evidence into a summary of finding and try to describe what the effect estimates are so it's easy to understand. Then we grade the evidence. And again, we do this with the methods team and with the GDG. Sometimes we discuss and debate, did we grade correctly? And then come to a consensus, and then come out with a plain text summary of what we think the study results are showing. And I'm just showing you this from the corticosteroids. These are the 6 pieces of information that go into a recommendation: the evidence, the values and preferences, the balance of benefits and harms, resource implications, acceptability, feasibility. And these are the 6 that we use. It's called the evidence to decision framework. We do this in a casual way, though. We do this during the GDG, not in the sense we allow free conversation about these topics after the evidence is shown in order to make the recommendation. And here you can see from our guideline is really the values and preference statement. Again, we re-looked at this statement with every GDG prior to looking at the data, just so we're clear about how are we, what is our preferences, what's going, if we get into a situation where we don't have consensus, can the group agree to some values and preferences in making their decision? And this is just an example of the corticosteroids, which was our first living guideline. And that was published simultaneously with the prospective meta-analysis, as well as 3 individual trials that reported on the same day their results as a package. And so that, I think, helped us write a transparent and trustworthy guideline. Here are our guidelines, and the Magic app is the electronic publication platform that we are using for this guideline. It's easy to update in that electronic platform, which helps us update chapters at a time in order to make that quickly available. And we also have our guidelines on the Academy, on an app, which is the WHO Academy app, which you can find, as well as transformed into training modules on openwho.org. And so where are we at now? So now convalescent plasma. So you've seen the data. So I'm not going to actually discuss the plasma, but I'm saying the WHO steering committee did trigger the update of the meta-analysis. However, we are aware that there's a couple of studies that soon will have their results pending. And so we are waiting for those 2 large studies to share their results, and then we will update the network meta-analysis. And so I anticipate our GDG for this intervention will meet in late July. I want to acknowledge that to make recommendations like this at the global level requires a massive collaboration at all phases of the process to be efficient, fast, and trustworthy. So this is only made possible by the incredible collaborations between the trialists, who have at many times shared data with us before it's public, to the methodologists that are supporting us from various different universities around the world, and the teams that are doing these systematic reviews, which are quite large, in order to make sure that they're accurate, but also to emphasize that it's not just one drug, it's a clinical care package that needs to be holistic and multidisciplinary, with staff that's trained to work in structures that are safe, and to make sure you have sufficient supplies and systems. So from the WHO side, we work on all these aspects in addition to the therapeutic guidelines. So I want to thank you for this opportunity.
Thank you so much, Dr. Diaz, and many thanks to you and colleagues at WHO for all that you're doing, including the clinical and the research response. Thank you so much. I'm going to request all the panelists to turn on their cameras. We will try, we're almost out of time, but we're going to try and extend for 5 to 10 minutes to take, a couple of questions at least. I'm going to start with Professor Horby. Professor Horby, there's this question about, if it's given early, plasma, if it's given early, would it make a difference? And Dr. Baumik was pointing out to me that the UCSF guideline says, if within 3 days of symptom onset, plasma should be considered. You did present some subgroup results of symptom onset, within 4 days of symptom onset. Would you want to comment? Is there any further analysis that you're planning? What are your thoughts about this? In some ways, ultra early use of convalescent plasma.
Yeah, thank you. Well, in some of the secondary outcomes, that there was evidence of heterogeneity by baseline antibodies. So perhaps shorter time of stay and less progression in the seronegatives, but it was a small difference. And you've got to remember that we've done multiple subgroup analyses, so there is some possibility that's a chance effect. And we looked down to 4 days or less, and even that subgroup was bigger than all the other trials combined. So that's a pretty big subgroup, and we didn't see an effect on mortality. So all I think you can say is that we haven't excluded the possibility of a benefit in very early treatment, but no one else has shown it. I think those that advocate for convalescent plasma use very early need to do an adequate trial to prove it works and not just assume it works, because we've seen a lot of assumptions that are not based on evidence. And I think the other question is the feasibility then. One has to question the feasibility of using convalescent plasma on an outpatient basis to prevent hospitalization, because hospitalization risks are not enormous. And so you're going to have to treat an awful lot of people with a product to prevent one hospitalization. So is it actually, even if it did work in that group, is it actually a practical intervention? That's the other question, I think.
Thank you. Thank you so much. I'm going to try and bring in Dr. Mukherjee. There is a related question around, another subgroup. So this is there in the NIH guidelines as well about whether, immunosuppressed patients, because they have a higher chance of or a longer duration of viral shedding, would they be someone that would benefit? As far as I know, there isn't enough data at least to tell us what we need to do there. But I want to check with you, Dr. Mukherjee. What do you think about that? Would you think that immunosuppressed patients, there is a chance that this therapy might work? What are your thoughts on that?
Yeah, as you said, there aren't enough data. There are just case reports where it is being used in immunosuppressed patients. As for in our trial, we did not have any such patients. Yes, but theoretically, we could say that yes, if they're not being able to mount their own antibodies, if we give passively from outside, it should work. But then again, on the flip side of it, we should also remember that if we are not able to give enough antibodies and we haven't been able to neutralize these viruses, will it lead to some kind of immune escape and variant development? Because there's one case report of that too. So we really don't know. Again, as Professor Horby said, we really need good trials to answer these questions. We can't work on assumptions right now. We can work on assumptions to a certain extent, but after that, we do need evidence.
Absolutely. Thank you. I think for all of this, there might be biological plausibility, but clearly we need high quality randomized control trial data to inform us on what we need to do. Thank you. I'm going to try and get Dr. Baumik in. Great talk. As clinicians, we witnessed some of those challenges of patients and families running around trying to get plasma, getting a lot of misinformation and so on. And clinicians obviously continue to believe that this makes a difference. How do we do this better? How do we improve the next time around? It's not just about the dissemination of evidence to folks that have access to Twitter and other social media, sitting in cities, sitting in large hospitals. But how do you make sure that this message goes out to any country's semi-urban centers, to the rural centers, and how can we help our healthcare providers make sure that they provide evidence congruent clinical care?
Yes, I think that's a crucially important question, which we really need to understand better. And there are a lot of assumptions also in this space. So we really need to understand this better through research, which involves social sciences approach, and also to understand how people perceive evidence and also the methods used for evidence. And from some work we are doing now, we understand that a lot of the methods are seen by a lot of clinicians too as something alien to how knowledge is legitimized in their own cultures, because the process of legitimization of knowledge is very different in different cultures, and because of that plays a crucial role. And but a very important part of this is actually breaking and starting at the guideline development space, because it needs to be owned by everyone in the system. It cannot be something that is developed at the top and being told you have to do this and this is the flow chart. It has to be co-developed with people, and not only just primary care doctors, but nurses, community health workers, and patients who are on the ground. And once we get all these social networks involved, and also bringing transparency and accountability in the process, I think a lot of the issues will get addressed. But this apart, also we really need to change the culture and make clinicians as well as patients understand that the focus of evidence is high value of a care should be high value care, or not on very minute effects which may or may not happen. And just one more line around is that it's very I mean, all these things are very easy to say, but quite more difficult to do. So this will need a long investment, particularly around also understanding that our guideline development process is not really tuned to do in pandemic, and Dr. Diaz is doing really great work on that domain. But we really need to, I think one of our reflections is that even for the same certainty of evidence, because the health systems and everything changes in the surges, the recommendations might actually be more dynamic in nature, depending on what stages they are. And these are things which needs to be looked on in the future.
Absolutely. Looks like lots of work for you to do and for us also to do. So thank you. Thank you so much. Dr. Diaz, I'm going to ask you a related question. So do you think that some of this difficulty in translating the evidence is related now, to the ever increasing complexity of trial design? We've conventionally all used to this 2 arms, 1 outcome, or some few outcomes, easier to understand, but trials are getting more and more complex. And we've seen that in the pandemic with REMAP, we've seen that with recovery, there are adaptive trials, platform trials. Do you think some of the difficulty that at least clinicians face is related to grasping or understanding, the essence of this trial design issues?
I think it's, thank you, Bharath, for the very good question. If I had the methodologists here, I will speak how they would speak. No, I think it's quite a challenge with the platform trials. I mean, I think they're outstanding trials, right, and able to be nimble and agile and study many different drugs, but you do have to be clear with the numbers of what's being compared at what time, especially when drugs fall out and what the controls are. So we did have in one of our recent meta-analysis, we did have that experience where we actually didn't have the right ends when we were doing the meta-analysis. So yes, we had to go back to the trialists and say, let us be clear with who was enrolled at this part of the time of the trial, who was enrolled at this part of the trial, how many controls are, because you won't get that necessarily in the publications. So you can see why, if you're just reading one publication at a time and then seeing how this gets meta-analyzed and ensuring that you're meta-analyzing it in the right way. And if you start adding the network stuff, it can be quite complex. So I do think it just requires, understanding the complexities of the trials, having good communication with the trialists and the biostatisticians of those trials if there's questions. And they've all been very supportive of us trying to get the best analysis possible, even when they're still as well trying to finish up their analysis for their publications. But I do think it adds complexities, and we'll see more of that, right? Because hopefully we'll see more effective drugs. And then, is it additive effect? or is it one drug or the other, are the options? And so these are types of questions that we'll have to, that we are tackling already, and we will continue to see over time as the studies continue. So a lot of thinking and preparation in the development of the guideline and looking at the data and how its practical use at the clinical level, like what is the doctor then, or the nurse, what are they going to do with this drug A, drug B together, separate, et cetera. So those are all things that we take into account. Thank you.
Thank you so much. Professor Horby, did you want to quickly comment on that, on the point about complex trial designs, the fact that the control arm is changing over time because the standard of care itself is changing over time, especially in a pandemic?
Yeah, I think there are different levels of complexity. I think the recovery trial is relatively straightforward in that it's a frequentist design, one-to-one, and you're only eligible to be a control if you were eligible for that drug. So it's fairly straightforward. I think some of the other adaptive designs are a bit more difficult to tease apart because they have adaptive randomization. And I think my understanding, I'm not fully aware, but it's a bit difficult to sort of unblind some of the controls because some of the other arms are still running and things like that. So I think that is an important consideration as to, you can get some efficiencies, but does that warrant the added complexities?
Thank you so much. I'm just going to have one final question for Dr. Aparna Mukherjee, and then we will try and close this. Dr. Mukherjee, you wrote actually an accompanying piece in the BMJ about the challenges of doing this trial in India, and you did allude to some of it today. But maybe in closing, you can share some of the reflections of not just pandemic research, but research in a very complex and diverse country such as India.
Yeah, because if we want representation from across the country, if we are to say that this works in Indian patients, it's a very difficult thing to say because we have such diverse population in our country. So for that, we believe that just doing research in a few elite institutions may not solve our problem. Definitely, it's going to give us proof of concepts, it's going to prove a hypothesis, but to do pragmatic trials and to do things that we can translate, we need to take it to all the parts of the country and what we try to say as democratization of the research. Only then we will get a representation of all the regions, their practices, the type of patients they get, and that I think will translate into more clinically meaningful results.
Great, thank you so much. I want to thank all the speakers for making time and for joining us today. It's been an excellent session. I want to thank all the participants. I want to thank the partners for this event, George Institute for Global Health, Apollo Hospitals, the Chennai unit specifically, the Indian Registry of Intensive Care, and of course, ISARIC. I want to thank the team at ISARIC who've been literally behind the scenes, Nina Jameson, and then we have Liliana Rezende, Sarah Moore, Jake Dunning. We have the communications team, Roman and Davide. Thank you all so much, and to Gail Carson as well. Thank you all. Have a great day. We'll close the session. Thank you.
Thank you very much.
Bye-bye.
Thank you.
Thank you.